Good morning, Mickey.
Good morning.
Is it cold up there like it is down here?
I'm freezing my ass off. I brought hand warmers today.
I'm sorry?
I brought hand warmers today.
Yeah, good. Why don't we go ahead and get started here? Actually, I'm getting some feedback here. Okay. What I want to talk about is three cases today that have to do with conditions that may or may not be job related as causes or complications. And these are all the cases that we've seen among the several of the DoD clinics. And I've asked Millie and Amanda and Tracy to just comment, since they were involved, giving some perspective from the standpoint of the clinic. So we'll incorporate that. And I'm anxious to have some discussion here. I'm hopeful that you'll suggest or respond to questions about how you might be managing these cases as you saw them in front of you in one of the clinics. So we'll go ahead and get started. Is my slide advancing okay now? To the second slide, can somebody tell me? Are you seeing golf balls?
No, it's still the tree, Dr. Schumann.
Katie, did that advance okay?
No, it's still the tree.
Okay. Did the slide advance? I'm not hearing.
Can you hear me? No.
There we go. Okay. Did it advance to the golf balls?
No.
Shoot. How about now?
No.
Oh my gosh.
Yeah. Go ahead and unshare your screen and try resharing.
Say that again.
You got it now.
Okay, now are you seeing the golf balls?
Yes.
Okay, good. All right. Technical challenge. In any event, so the situation, the first one is a case in which pesticides on a golf course for a golf instructor and Parkinson's disease. Question is if there's a relationship. So here's the clinical picture as this patient appeared. And do you see my summary now for the patient?
No.
Do you see it now?
No.
Good grief. Wow. Ay, ay, ay. Do you see now that about the patient?
Yes.
Okay, I'll just leave it on this end. So in any event, 57-year-old male who works as a golf pro instructor at a local private golf club where he's been employed for 40 years, presumably on a full-time basis. He reported episodes of feeling lightheaded and brain on fire starting on November 2nd of last year. He said that he was out on the driving range the day the symptoms started. He also indicated he had several subsequent similar episodes since that time that resolved after a few hours. He noted some difficulty with speaking as well. So came to the clinic with those complaints that started in early November of last year. Do you see the slide advancing now?
Yes.
Okay, thanks. So he commented that chemicals had been sprayed on the golf course the day of onset of symptoms, as well as routinely, so that there were chemicals being sprayed on some sort of regular basis out on the golf course. He stated also that there was a ponding basis on the golf course that was dredged at one point, and the sludge from that, the bottom of that ponding basin was placed close. It was on the grass somewhere close to where he teaches. He didn't have a date on that. He had the sludge independently tested, and chemicals were found, including those in Roundup. He also had a list of different chemicals that are used on golf courses. So he had had some studies done, laboratory studies done on the sludge. There were some chemicals found, and then he had apparently gone online and found a list of chemicals that are used on golf courses as well. And part of the history, in 2018, he had been diagnosed with Parkinson's disease, and a neurologist had told him that the disease in his age group was likely due to chemicals. So going online to identify what chemicals or what categories of chemicals might have been present, a variety of fertilizers are used, and then among potentially toxic chemicals, pre-emergent herbicides, fungicides on various bases. Some are contact, some are systemic, insecticides, growth regulators, plant stimulants, and maybe others. So these are seemingly the categories of chemicals that are used on some basis on golf courses. The patient's additional history: his father had Parkinson's disease in his 90s. Patient's current medications included those listed, a couple for Parkinson's disease, one for anxiety and depression, escitalopram, trazodone for depression, insomnia, and vitamin B12. Physical exam was apparently unremarkable when he was seen. So Millie, you had seen the patient along the way. I'm not certain if you saw the patient early or later. What was your take when you first saw this person?
So when I first saw him, and it was probably, I can't remember now the first day he came in, but it was several weeks after that exposure that he reported his brain on fire, and that's obviously his concern because it was the same day of the pesticides. He's a very nice gentleman. He's got some tremors, obviously, but it's pretty well controlled. At that point, I think he was looking to get some answers as far as the current exposure, as far as his headaches, his altered ability to speak very well. It laid him up for about 2 to 3 days that last time that he had the exposure. So, when we were talking and he was talking about his Parkinson's, he had mentioned that the Stanford physician neurologist had mentioned that the pesticides is a possible cause for his Parkinson's, and certainly his concern was if these continued exposures were going to make his Parkinson's progress faster than it already was. So plus it affects his ability to work as a golf instructor when his Parkinson's is not doing too well. So he has all these concerns. Obviously I'm not going to make that determination whether or not the chemicals induce the onset of Parkinson's. And could the chemicals that were recently used cause neurological symptoms? I certainly don't. I don't know that either. But he also mentioned that he has several of his neighbors within the golf community. He lives in the housing on at the golf course, and he's lived there for a lot of years. And he noted that some of his neighbors also had been diagnosed with Parkinson's. I don't know the age of those neighbors, though, or whether it is or isn't, a condition that would be, something related to the spraying of the golf course. But he's got a neurology or a toxicology appointment this next month with UCSF toxicologist. We'll see. He did tell me at this last visit that he had seen a toxicologist a number of years ago or at some point in the past. And he told me, we kind of left the conversation a little bit short, but he told me that the toxicologist had indicated that it likely was chemicals that he was having exposure to that were causing his neurological symptoms. But he stopped short of naming the golf course obviously liable. So we'll see what this guy says. So still waiting.
Yeah. Did he intimate, or was it his thought that the Parkinson's itself had caused the chemicals had caused the Parkinson's, or was he feeling that perhaps he had Parkinson's and it was making his symptoms worse somehow, or was that, could you tell, did he say one way or the other?
I think he was really questioning because of the early onset of his Parkinson's at the age, he was diagnosed at the age of about 53 or 54. That the early onset of the Parkinson's, he thought that it might be chemically related.
Mm-hmm.
Especially because the guy has been at that golf course and worked as the pro for, well, he's been there for close to 40 years. Now, he started when he was a young kid and has always worked at at golf course, and I think this one for probably most of his life that he's had the job.
Yeah. So you weren't certain, and I would say at this point, there's not enough information to really know one way or the other. I think probably the position that you were in was, is it possible that this might be a factor, but you weren't going to determine this at the outset.
Yes. Yeah, because I honestly, I don't, that's not my, that's above my pay grade. Let me put it that way.
Right. Yeah. Well, and I wouldn't have known that either. What information would you have, or might you have wanted at that point, beyond what you've said so far from this fellow?
Well, the information, again, he's got a lot of documents as far as the type of chemicals that have been used. So he has a portfolio of information that he obviously can present to the toxicologist for them to look further into, if how they work that up. But, the onset, the young onset, any other family history of early onset Parkinson's, which was not the history. That's the only thing I can think of that I would want to know.
Right.
The interesting thing though was that the couple episodes that he had of his headaches, his brain feeling like it's on fire, his inability to form words for a few days after the recent sprain, and then there was a time before that. So he's had a couple episodes that most of the time he doesn't have to be out on the golf course when they spray because he's an instructor. But the times that he's had some of these headaches and the buzzing in his head and the neurological changes in his speech pattern that sometimes lasts for a few days. So
Mm-hmm.
I don't know.
Right.
just quite unusual.
Yeah, there's some information that we would like to gather, which the toxicologist presumably would want to know. And I would say also that this has implications beyond just golf courses. Where I've seen this more in the past has been with agriculture, spraying out in the fields, and then farm workers being potentially exposed, as well as we work with some companies that formulate pesticides, and there can be potential exposure there. So this can be certainly a golf course issue, but it, in our area, can also be an agricultural issue, and in manufacturing as well. What I would say is to make a determination as to whether pesticides or chemicals most broadly are a factor, is almost impossible to make a judgment without knowing, frankly, what the chemicals are. So it sounds like he had a list of those. And what's supposed to happen, I don't have much experience with golf courses, but I know in ag and in all other industries where employers are using chemicals in any form, they need to keep a list of those, and in fact need to have on site copies of the material safety data sheets, which an example which I'm going to show in a minute, for any chemicals to which employees are exposed. And those are supposed to be accessible to employees. And in fact, when employees come in to see us, they really should be bringing either a copy of the MSDS or at least a list of the chemicals to which they've been exposed. It's really hard to make a judgment about chemical toxicity and potential medical problems with patients, employees, if we don't have a list of what those chemicals are and have some sense of what the side effects potentially are. Some are respiratory, some are dermal, some are neurologic, target organs, kidney, liver can be involved. So we really need to have a list of those chemicals. The second thing we really need to know is how they're being used. Some chemicals are sprayed. From an agricultural standpoint, they may be sprayed from helicopters. In many cases, they're just sprayed on the ground by tractors pulling spray rigs. Sometimes they're spraying just manually, employees walking around appropriately covered and using manual spray equipment. So we would need to know what the chemicals are, what the frequency of spraying is, and what's the form of distribution. Some are in powder form, particularly on grapes for mildew. Others, again, are liquid and sprayed. And then the other thing is, for almost all chemicals, there's what's called a re-entry period. It's the period of time after which employees are safe to be in the area where spraying or where chemicals have been distributed. So we'd really like to know what the re-entry period was, and if an employee was exposed to the area of spray or distribution of chemicals within the re-entry period, not waiting until the re-entry period had occurred. So that kind of information needs to be known to make a reasonable judgment as to what the degree of exposure is. The other thing, frankly, that can be an issue in these cases is, we're all exposed to some degree, or many of us are, chemicals at home, whether we use Roundup to spray for weeds or we use other things that we spray on grass for crabgrass and other substances. So the only exposure isn't necessarily confined just to the workplace. So we need to have some sense from the employee, the patient, if there's been other exposure to pesticides, to chemicals outside the workplace. So what was the initial assessment? I agree with your judgments, Millie, and what you did. And I think getting into a toxicologist is the right thing to do. And hopefully between the patient's information, and maybe whatever is available from the employer, some of that, the information I described would be available. So what's the initial assessment? Well, possible, but the patient's known to have Parkinson's. So the question is really etiology, and with the initial assessment, maybe relationship to the any chemicals that are being used. Maybe causation, but more likely the possibility of aggravation, exacerbation based upon chemical exposure. It's significant that the patient's father had Parkinson's disease, and certainly the most common scenario of developing Parkinson's is within a family. It's genetic, but then there are other possibilities too. So what are the diagnostic options? Well, just what we've talked about. Ideally, and it's really a little difficult in this particular case, but when we're evaluating a patient, what we want to do is develop a differential diagnosis and then a working diagnosis. And I think we're generally taught, although this isn't always easy to do, but it's the chief complaint, the history of present illness, the family history, and the review of systems that should give us the ability to generate a differential diagnosis. And then ideally, with a physical exam, determine at least a working diagnosis, whether or not we're certain of that working diagnosis. And so in this case, the differential is etiology, that's Parkinson's due to genetics or some other non-industrial cause, Parkinson's due to chemical exposure. So what are the next steps then? Well, as mentioned just a moment ago, we need to gather more information about the chemicals, whether it's on the golf course or whether it's ag or somewhere else. And so what are the chemicals used? Sounds like the patient provided that. And then the information that we discussed about how the application is, what the schedule is and the format of application. And then some sense of extent of exposure, how often the employee, in this case, the golf instructor, was in an area where some sort of pesticide application had occurred. And then also we want to have a sense of, from whatever chemicals we think are a factor, what's the pathophysiology and the adverse effects. And so we look those up. We would hope also that the neurologist who made a comment about the possible cause of Parkinson's or aggravation of Parkinson's, what categories of chemicals he thinks might have been a factor. It's really not quite that helpful if the kind of the general statement of chemicals is made. It really doesn't put us in much of a direction. So the toxicologist will be giving some help there. Just to mention the material safety data sheets, I'm not sure how many of you have seen material safety data sheets before. Let me just bring this up. Here's an example of a material safety data sheet. Can you see this material safety data sheet I put on the screen?
Yes.
Okay, so material safety data sheets, what you do the way to find these is take the chemical name, and that's either the brand, which may include several components, or the specific chemical in question. A number of the chemicals, pesticides in particular, have several components. So it's best to go to the brand name, whatever the trade name is for the chemical. And they all follow the same format. And in this case, we have one of the organophosphates here, which is a single component. And then if you scroll down to 3, hazard identification, it'll give you some information about what the likely route, in this case, likely routes of exposure are, how the chemical itself is likely to be absorbed into the body, in what body organ systems. So category 3 is typically helpful. Category 4, if we see acute intoxication, now this was not that case, but sometimes we'll see folks that have been exposed acutely to pesticides, organophosphates, carbamates, and others, and we may need to provide first aid. And so there's information in the material safety data sheet about that. And then if you scroll down to section 11, they have toxicologic information. And this is what determines or helps determine the toxicity. There's category 1, 2, 3, and 4. And the toxicity of any chemical is based upon the lethal dose, 50% lethal dose of oftentimes rats, sometimes other animals, and it's based on milligrams per kilogram of body weight of the animal. Now, that's hard to extrapolate to the human, but it gives us some information about how toxic a substance is. And so those that are most toxic, category 1, actually take special licenses to use. Category 2 is something like most organophosphates, malathion, and category 3 and 4 are minimally toxic and generally don't represent much of a problem. So we'd like to see the MSDS. We'd like to know information about the particular chemical, particularly if it's an acute exposure, and then provide that to the toxicologist or whomever is going to treat the patient. So going back to this. So, and there are signal words that are referred to on the packaging. And so danger is category 1. They sometimes use the word poison, warning, and caution. So you may see those. That's not really applicable in this case, but in cases of acute intoxication, this will be useful. So the other thing we can do, and I went to up to date just with some brief look, and there are a number of studies about pesticides and or chemicals and Parkinson's, but they tend to be categories and not specific. And in most cases, there's reference to needing additional studies. So there's not a lot that I could see that was immediately available for making decisions about pesticides, chemicals, and Parkinson's disease, but the toxicologist should be able to give us some help. So Millie, maybe I could look back to you again. What was your thought about, part of our job is making a decision about job causation, realizing that there wasn't a lot of information, difficult to conclude. What was your preliminary assessment about job causation in this case?
Well, I really didn't feel comfortable saying that there's a job causation. I certainly think that there's some links that are concerning. The fact that he had worked, around the golf course for so long, the fact that he had classes right next to this sludge for a period of time. There was in his recurrence of his headaches or instances of the headaches when he's been out recently after they sprayed whatever they have been spraying the last number of years. I think that I certainly wanted, I could correlate perhaps symptoms with the headaches and stuff with the spraying, but for the Parkinson's part, I think that needs to have a little more investigation that I wasn't comfortable making.
And I would agree with that. And you recall that in job causation, we make two decisions here. One is we identify what the patient's problem is, whether they're symptoms or physical findings or both. We have that on one hand. On the other hand, we have the question of, was there an exposure or an event on the job that might have either caused those symptoms or physical findings or aggravated those? And the graph on the slide here is a recall to what we've discussed previously. Is it possible that the event or the exposure caused the problem or materially aggravated the problem, which would constitute a job-related relationship? And the second decision then is, after we've determined if there is a possible relationship between work and whatever the event was, condition, or is, then how certain are we of that? And if we think it's more likely than not, we say it's probable, and that constitutes job relationship, a decision of job relationship. If we think it's only possible, less than 50% likely, that doesn't necessarily constitute a job relationship. In fact, would generally not. And then the other possibility, which I think is appropriate, is just to say uncertain, that we really don't know in a case like this. And the carrier actually would prefer, if we really don't have a good sense of this, an uncertain conclusion at this point, and then refer for consultation, which is what happened appropriately in this case. So I would say possible relationship, but uncertain. We're not in a position to make a decision at this point. And then the next steps, your treatment plan. Well, workup, there's not a lot for us to do in a case like this. It's really a matter of making a referral. What do you tell the patient in a situation in this? Did you discuss your opinion or your thoughts about this with the golf pro, or not so? What did you tell him?
I actually told him that I didn't know for sure that this might or might not be related to the Parkinson's headaches. I thought that likely that the exposure was causing the headache issue, but we just needed to get the toxicologist involved to see if he can make a relation to the chemicals and his symptoms.
Right. And that's appropriate. Most of the time, we at the outset, we need to make, when we first see the patient, some sort of decision about job causation. And ideally, we would be able to say it's more likely than not, or less likely than not. But in some cases, we just really can't. And so we end up turning to the toxicologist, or whatever the appropriate specialty is. What do you think the carrier is going to do in this case, where there's uncertainty about considering it at job related? What do you think the carrier is going to say in response?
They probably would put the claim on hold, I would suspect, for further information.
Yes.
Yeah.
That's right, on delay. And how long do they have? Do you recall to make the decision?
90 days, I think.
Yes, that's right. And what happens when a case is on delay about paying for the cost of care? And if the employee, what did you do work-wise? Did you take him off work, or did you leave him at work, or what did you do?
I left him on his normal job because he's a golf pro. He can pick his schedule a little bit, and he's trying to avoid the area, obviously, when they spray.
Okay, that was good. I think that was appropriate. And there are two, in terms of compensation, there are two issues here, only one of which applies in this case. One is the carrier during that 90 days will pay up to $10,000 as long as care is being provided according to the medical treatment utilization schedule. So the cost of care is covered up until they make a decision. And if they decide based upon whatever additional information comes in, it's job related, then it is job related and they continue to pay for care. If they decide it's not job related, then they don't cover care after that point. The second issue in the situation like this is if the employee is off work, no disability is paid during that time that a case is on delay. So if we take a patient off work and the carrier puts it on delay, there's no disability paid. If at the end of or at whatever point they make a decision about this, then they'll go back. If it's decided to be determined to be job related, they'll go back and cover lost wages. But if it's determined not job related, then at no point was disability paid to the employee from the carrier. So referral appropriately made. When will the patient be MMI? Who knows? We don't know at this point. In summary, just the important non-acute chemical exposure, whether it's golf course, ag, any place else, get an accurate history, determine the chemicals that are possibly involved, determine the extent and timing of a possible exposure, what's the nature of the exposure, how often is spraying done, and get the MSDS and understand what you're talking about. Then construct a differential diagnosis. What are the possible causes for the problem? And then you make at least preliminary judgments. You make a decision about causation. You make a decision about management. What's the plan? Are they going to see a specialist? Is there additional workup you need to do? And then you be prepared to make a decision down the road of conclusion of care when that's appropriate. So this applies to the golf courses, it applies to ag, and applies to any other place that people are exposed to chemicals, frankly, including their home, when the issue arises there. So any questions on this from anybody? Good job, Millie. Okay, let's move on to another one. So second is an interesting case. Do you see my slide about incidental finding on X-ray? Is that visible? Anybody?
Yes, but we can still see the other slides on the left-hand side there.
Okay. And now do you see my slide on the patient? 54-year-old female. Do you see that slide?
Yes.
Okay, thanks. All right. So this was an interesting situation. 54-year-old female who does data entry. On 11/2/21, she's lifting a box of heavy files and felt a pulling in her shoulder, self-treated with ice and heat, lidocaine cream with some relief of pain, but incomplete relief. 12 days post-injury, she came to doctors on duty reporting a 8 out of 10 pain in the right shoulder radiating to the neck and length of the back. Pain is worse with motion of the shoulder. She denied any similar prior problem. X-ray of the shoulder revealed an AC joint degenerative changes, rotator cuff tendinopathy, which is a little bit hard. That was on the report, but hard to tell on an X-ray. And there was a heterogeneous intramedullary sclerotic density in the humeral head and neck of the humerus, measuring 4 by 2 centimeters, having the appearance of an endochondroma, or low-grade chondrosarcoma. So Tracy, along the way, I know late in the case you you saw this, but what sense did you have about this?
Hi, everybody. So when I saw this patient, it was probably her 4th visit, and it was her first visit to discuss her MRI results. So I had to explain to her the differential of the enchondroma versus low-grade chondrosarcoma. And she was initially very concerned, but when we talked about her injury, she also started to believe maybe it's not related, but she still had to voice her concerns and how she was worried about the diagnosis.
And what did you say to her?
I told her based on the MRI, it's not likely to be the chondrosarcoma, that based on what it looked like, it was more likely the enchondroma. We talked more about her history, if she had any night sweats or pain at the location, if she had any weight loss. And after that, she felt a little more reassured, but still had further questions.
Good. And what sort of referral was made?
So we talked about making a referral to orthopedic surgery for further testing because she wanted more definitive answers.
Right. Now, and so this appropriately goes to the orthopedic surgeon to do whatever needs to be done. From the work comp standpoint, what would be the issue here, and what were the diagnoses involved, and any possible relationship to the job?
So the issue here was this lesion likely was there before her injury. So we talked about, would it be related to what happened? She said that she lifted a heavy box, and felt pulling in her arm and neck pain. So considering the mechanism of injury, it didn't seem likely that this was related. So that would be one of the issues with this case.
Right. And what was your impression of the cause of the pain that she was having?
It was kind of difficult to assess by that point because she didn't have much pain at rest, only with movement. So having months gone by, I didn't really know what she started with as her baseline of pain. But talking to her about the location of the lesion and then where her pain is, it's mainly in her neck and in the shoulder joint itself, not so much where the humeral head is. So it was kind of difficult to assess on that impression of just talking to her about this MRI that I didn't really know much history about.
Right. And the MRI showed some evidence of tendinosis, apparently.
Mhm.
And so the decision would be, excuse me, how many things are going on here? It sounds like two things were going on. One is she had some tendinosis of the rotator cuff, musculature, and maybe clinically thoracic paravertebral muscle pain. And then she had this tumor, whether benign or not, going on. So there are two things going on. So regardless of causation, the orthopod needs to be involved in making judgments about what's to be done about what's found in the humerus there in terms of the lesion. From the work comp standpoint, the question to be answered excuse me, is whether what she had, her symptoms, whether there was something, whether there was a relationship between the findings on the X-ray and MRI and the findings there and her symptoms. Are we talking about two independent issues, one being an industrial straining injury, perhaps to the shoulder from the lift, and then the event, the finding on MRI of the lesion? And the question then, is there a relationship between the two? Or are we talking about two entirely independent conditions? My sense of this in looking at the record, trying to recognize what probably happened is, I think it's more likely than not that two things are happening that are unrelated. One is that she had a straining injury to the shoulder from the event on the job. And then there's an unrelated lesion in the humerus, serendipitous finding that was unrelated. And the question would be, and if we look at our little graph here, if there was something about the work event that caused any symptoms related to the lesion in the shoulder, whether it caused the pain or materially aggravated somehow the humeral lesion, that would constitute job-related causation. If that's not the case, then these would be two independent events, the two independent conditions that would be managed separately. And in that case, there would be a judgment about the straining injury, and it may well be she needs some treatment for what seemed to be perhaps a straining injury from the lift. And then she goes to an orthopod or whomever to manage what's going on in her humerus. And that would constitute two separate records. And potentially what we would probably do, unless she had, well, if she has a family physician or not, get her plugged in with the orthopod, and then we wouldn't have anything more to be done with that if we believe that there was no relationship symptomatically between that and the industrial event. And we would then continue to treat the back and shoulder pain if we think that that's a straining injury with tendinitis, tendinosis, treat that as if there was no humeral lesion present. I'm inclined to think that that would be the case, and maybe some amount of treatment for the back and the shoulder pain is appropriate. Did you have a sense of that one way or the other?
Yes, we sent her to physical therapy for her shoulder and her neck. And then on follow-up, when I talked to her for her second visit with me, I didn't bring up the lesion at all to see what was her take after having some time to think about it. And she didn't bring it up. So I kind of left it at that maybe she'll see the orthopedic surgeon, have an evaluation and maybe some reassurance. And that would probably be the end of that part of the case.
Right. So was a referral actually made to ortho or not so?
Yes, it was.
Okay, good. Okay, so that I think is the proper management of this. Now, let's just say hypothetically, if you thought for some reason that the pain she was having was related to the enchondroma and it got a little bit worse with this lifting injury, what would be the industrial responsibility for treating that? Would the carrier be responsible for the enchondroma for the rest of her life, or not? Would there be some other consideration about extensive responsibility? That may not, I'm not sure if that's a clear question and it may not be easy to
Yeah.
answer.
It seems like a difficult answer
Yeah,
to
let me,
formulate based on
yeah,
the short history. I don't believe she had any history of pain there even before this. So my guess would be that whatever aggravation of it, as far as if she needed more physical therapy, maybe that would be appropriate.
yeah.
But
Here's
maybe
what,
removal of the lesion, I wouldn't be so sure about.
yeah, here's what I'm getting at. In the case of a pre-existing condition, and we've talked about this before, if there's an aggravation, if that pre-existing condition is made worse, then the responsibility of the carrier is to get the patient back to the pre-injury state, symptom-wise, not necessarily to become responsible for that pre-existing problem, but just to get the person back to the pre-existing condition they were in, which on the graph would be that E dotted line. So that it's really hypothetical here because we're saying that there doesn't seem to be a relationship. But if we thought there were, that would be the approach. So I think the right things have been done. I think segregating the two problems, non-industrial follow-up for this serendipitous finding was correct. And then we just treat the shoulder to whatever degree as if there were nothing going on in the humors. So that sounds good. Good job. Any questions from anybody on that?
I actually had two questions. One
Did I lose you, Amanda?
was, Julie, I was curious what on the diagnostic made you come to the thought that it was more likely to be an enchondroma than a sarcoma?
That looked to me to be the MRI report that the radiologist felt that it was more likely an enchondroma based upon, as I recall, I think there was no disruption of it was confined to the medullary portion of the bone and didn't involve the cortex. There was no evidence of invasion of the cortex.
Oh, good. It did say that. Okay. Just curious. Thank you.
But it may well be that an orthopod would think a biopsy would be appropriate. I really don't know. But the tentative impression of the MRI on the MRI was of the former enchondroma. Did you have another question also?
Yeah. Do enchondromas cause pain? Because everything I have read indicated they're not a painful lesion.
Yes, that's true. And that would also be a useful consideration in making the decision here. So I think, there are no symptoms from that to have been made worse. And I think the symptoms are attributable to the physical injury, the lifting injury. And I think this was a silent lesion, the lesion in the humerus. All righty, let's go on to one more and featuring Amanda. So this is also a really interesting case. Patient is a 39-year-old female, works at the Santa Cruz County Sheriff's Office. Patient has a history of rheumatoid arthritis, was diagnosed in April of 2021, sees a rheumatologist every other month. She came to a doctor's on duty this month on the 10th, to document that she believes her rheumatoid arthritis is a direct result of working graveyard shift and shift work in general. She has done a lot of research that confirms the correlation between shift work, specifically in rheumatoid arthritis. She has no family history of rheumatoid arthritis. She went on disability 10/21/20 for wrist, as well as multiple other times for individual body parts at different times in her career. Her left wrist and both feet currently disable her. Her left shoulder goes numb. Left hand gets so swollen she cannot use it, and so has been unable to work. Physical exam reveals left wrist and hand swelling. So Amanda, what was your sense of this case when you saw it? Morning. Amanda, I'm not hearing you. Did I lose Amanda? Are you there?
You did lose me, but I just got back. Sorry, I'm driving, so there's a spell where I lose
Oh,
reception.
Sure.
Sorry about that.
No, thank you.
Did you
Yeah, just
did you ask?
what was your sense when you saw the patient with the rheumatoid arthritis and her postulation that there may be an industrial causation?
I could tell it was going to be a long visit.
Yes.
She was, there was no question in her mind. This was directly related. She had done all of her research, and all of her research told her exactly that. And her rheumatologist had confirmed it to her. Yes, she had been on disability many times, and she didn't have the RA before she worked there, and she developed it 2 years later. However, she'd been working there, I can't remember, 15 plus years. So since she was in her early 20s. And so, yeah, I mean, she'd been out many times. She said specifically the problem was the shift work because she could never adjust to a specific schedule. And she just wanted it documented. She didn't realize initially that part of this process was that me being the primary provider was part of believing that this was true. She just thought it was kind of like documenting it. So that my sense was it was going to be very difficult. And I wanted to be really sensitive to it, but I did not, I wasn't on board with believing that this was a direct relationship. I asked her, she said it was directly related. And I said, okay, well, proving causation is a very, it's almost never said in research. So was it correlative? Because most of the time that's what they say. And she actually went back in her notes and actually did see that it was a correlation, not a causation. And I think that kind of was a light bulb for her on initial, at the very beginning. So.
And what did that influence her thinking about relationship to work or not?
Not really, because she just kept saying, I know my body and I know I didn't have this before and now I do. And I tried to tell her, the onset of RA for most people is not, when you are young. It's not when you're a child. A lot of times it doesn't develop till your 20s or 30s. And so it could have just been triggered, but that it is genetically predisposed in many people, and that perhaps there was a component of this triggering it for her, but that she would have likely developed it at this time in her life regardless. And she did not believe that. There was nothing in her mind that was going to be believing anything other than that this was causative.
Right. You know, there are two thoughts I have in this sort of situation, whether it's something like this, you know, this particular case or something similar. One is there's a legal concept, post hoc ergo propter hoc, which what it describes is it's the translation is some. I'm not an attorney nor a Latin speaker, but it's following therefore because of. And we run into these situations medically where something happens and patients will conclude because they never had it before and an event occurs that it's therefore due to. And that unfortunately is not proof of existence of a relationship. The fact that something follows something else, it just the correlation, but it's not necessarily causation. So we keep that in the back of our minds that kind of situation can occur. The other thing is it's just about never productive to try and talk people out of whatever their opinion is about this or almost anything else. And so my approach is to sort of lovingly say, well, you know, it's possible. You know, it's not possible. Things can happen that we don't expect. But I also lovingly say, you know, the likelihood is really pretty low. And it's hard to believe that there's really a relationship, but I'm not telling you that this can't be possible. And that more needs to be done to determine, whether or not causation has occurred here. And so in that, it's a matter to some degree of doing whatever research we need to do, whatever testing we need to do, and making whatever referral. And as I looked at it went to my favorite resource of Up to Date. There's some information about that. Just to review a little bit what our process is, we make a preliminary assessment, what concurrent conditions, what other conditions might be going on that have caused the problem. We come up with a differential diagnosis, and then we take the next steps. To consider rheumatoid arthritis, far and away the greatest, most significant causation is familial, that it's genetic. And everything else is a good deal less than that. There's some relationship with older age, female sex, some ethnicities can be factors, but those are largely genetic. Some lifestyle, cigarette smoking, apparently there's a correlation, poor diet, obesity, physical activity. Some of these seem to be less significantly related. Some environmental risk factors, some occupational exposures, but apparently the primary one is airborne inhalants, particularly silica, seem to confer greater risk. And then there's some suggestion that living proximate to traffic fumes can be a factor. So there's a lot of soft relationships, but certainly genetic is far and away the most common one. So what do? Well, what's our tentative diagnosis? We know the diagnosis in this case, just like the Parkinson's, is made. So we know that. But what's the relationship between work and, in this case, the rheumatoid arthritis? Well, is it possible that job caused the rheumatoid arthritis? Is it possible that rheumatoid arthritis existed and was somehow made worse by the job or something else? And then what's our level of comfort on this? What was your conclusion? You concluded, you told her that you felt that it was not likely that this was the case. How comfortable did you feel with that? What was your level of confidence?
Oh, it was really hard. I've only ever told one other person I didn't think it was related. It was an anxiety case and he wasn't happy with me. But after talking with you guys extensively, there was nothing that I could even say would have caused an exacerbation. There was no specific injury. It just, as you guys had talked about, just the normal ebbs and flows of RA. I think she was so convinced because she'd had no family history. She was not overweight. She didn't smoke. She didn't have unhealthy eating. So for her, this was just it. And she wanted me to read all of her research. And so I sat down, and I think it helped her that I at least took the time because I told her initially, I was like, I have no idea. This is not something I've ever come across, and nothing that I have ever heard would say this is related. But I want to give you the benefit of the doubt and try to find some way that, we could help you. And so at least I think by going to you and Dr. Pricey, she could see that I was at least trying. But when I sat down with her, I was like, I don't want to discredit the discomfort that you feel and how inconvenient it must have been to go through all of this and have to keep going out on disability. But from my standpoint, I can't see that this is related, but it doesn't have to end there. I'm only the first step. So you can still, even if I'm saying it's not related, from our standpoint, that's what I conclude, you can still go to the adjuster and pursue it further, and they can request a QME evaluation, which I feel like is a much better suited person to be doing something like that than me. Especially because I know that there's no rheumatologists within workman's comp that would even see her to treat her. So she took that fairly well. She at least, and she was like, yeah, this is definitely not over. I've got my lawyer. She was ready to gung-ho fight, but she was not upset, at least with me in that. Because I did try, I tried to find some way that I could help her with it, and even told her, hey, we can, if there was a way that I could find some way her wrist was upset with an event at work, then maybe we could get her PT, but there was really nothing had happened to have caused it. So we couldn't even go that avenue. So.
That was really well done, Amanda. I think what we need to do in these cases is be sure that the patient knows that we care, that we're trying to help, that we're honest with them. If we really don't, we know the answer, we tell the patient that, but we tell them that we'll do whatever we can to get them going in the right direction. And so you did those things, and that was really very good. Most of the time in a job causation, fortunately in work comp, the situation's pretty straightforward, but that's not always the case. And this one, plus the other two we've talked about, have various degrees of question as to whether there's causation or not. In these cases, the situation is clear. I mean, there's a diagnosis of Parkinson's or the lesion in the humerus or rheumatoid arthritis, but what's the relationship to work? And if we're just really not sure, then on the first report, we just put down, we're really not sure, and we make a recommendation for whatever, additional consultation. Toxicology for the first case was right, and I get the MRI in the second case in ortho. In this case, I think probably a QME, you're right. There aren't many. I don't know what rheumatologists, there may be somebody, but it's hard to find specialists that will see these or that really understand workers' compensation. And so it's best to discuss it with the carrier or recommend a QME. QME, of course, is not something we can request. That has to come either from the applicant side, meaning the patient, or the defense side, meaning the employer and the carrier. Those are the two that would ask for a QME. So we would recommend that the carrier would get a QME. But then also try and make the decision that whatever the baseline problem is, the rheumatoid arthritis, there isn't something on the job that's at least aggravating the symptoms. And this goes back to what we talked about with the last case, that if the symptoms are made worse, but the condition is not caused by job, then the carrier will oftentimes provide or authorize treatment to relieve the symptoms, but not solve the underlying disease process. So this was correctly done, and we would see what the specialist would say about it. So anyway, really good job on that. So treatment plan, we just really kind of mentioned how to go about that. And then in a case like this, we obtain an accurate history, we construct the differential diagnosis, and we're not talking about symptoms, but we're talking about actual diagnoses. And then we make a judgment. Is there causation? here, what's the extent of causation? What's the management constructive plan? So you know you're going with this. And then way down the road at some point, conclude care when that's appropriate. We're over 8 o'clock. Thank you for attending. If anybody's got any questions, I'm available. You can email me or give me a call. But thanks very much for attending this morning. Talk to
Thanks,
you
Dr.
later. Have a
Schumann.
great- Yes,
Thank you.
thank you.